So welcome to this session on neuro-interventional procedures and platelet function issues. And to join me here, I'm Professor Rob Story, Professor of Cardiology at Department of Cardiovascular Science in the University of Sheffield. We have today Dr. Guillaume Taylor from the Department d'Anesthesie, Reanimation in Paris in France. Welcome. And Jeff Dallin, who's the Chief Scientific Officer at Acumetrix. Welcome. So, first of all, we'd like to consider the role of antiplatelet therapy in neuro-endovascular procedures. And what are the sort of patient populations that we're talking about here and dealing with on a day-to-day basis?
The population is not strictly equivalent to the one you're used to in cardiology. Stents are used to treat aneurysms before perforation, before bleeding, preventing bleeding. And we think there are about 3 or 4% of patients in the general population who do have aneurysm that could bleed one day, and they may require treatment to prevent this bleeding. So we're not dealing with patients with arteriosclerosis like patients in cardiology, but any patients, and usually they're much younger. They don't have the comorbidities like diabetes or heavy smoking or cholesterol like cardiology patients. So anyone can have an aneurysm and require a treatment with a stent and dual antiplatelet therapy. Using of stents to treat aneurysms is quite recent. Stents have come to the market in about 2002 for the treatment of aneurysms, and more recently flow diverters, which are a different kind of stents that can treat aneurysms without coiling, in 2008. So neuroradiologists, who initially were formed as a diagnostic imaging radiologist, had to learn the use of antiplatelet therapy. They did not learn this during their medical studies like cardiologists. And because patients require general anesthesia for these procedures, we anesthesiologists have been asked to participate in the management of dual antiplatelet therapy for these procedures.
Okay, so we're talking about fairly small aneurysms, intracranial aneurysms that you're closing off with a stent?
They can be small, they can be bigger. It depends on patients. We have the smaller ones are about 2-3 millimeters in diameter. The bigger ones can be up to 2 centimeters, the giant ones. So there's quite a wide range of patients of aneurysm sizes. And stents can be used either along with coiling, like a scaffold to hold the coils in place inside the aneurysm, or solely to divert the blood flow away from the aneurysm. These are the new flow diverters.
Right. Now, is the aneurysm clotting off during this process?
It clots off a few days or a few weeks after the treatment. So the patient is not treated right after the procedure, especially with flow diverters. We believe it takes up to 6 weeks for the aneurysm to clot off with flow diverters. And for coiling, the coils usually take up about 70 to 90% of the volume inside the aneurysm, and then the clotting off does the rest of the work for us.
So if you put a coil in, how quickly is that clotting off?
During the procedure, we use high doses of heparin. We use the ACT to monitor the heparin doses, and usually we try to be between 250 and 300 seconds with the ACT. So it's a quite high doses. So usually the clotting off takes place a few hours when the heparin has washed away.
Right. And does that lead to any problems sometimes when the aneurysm clots off?
The clotting off is the actual aim of the procedure, so I wouldn't say it leads to problems, but using stents, we've had thrombotic events more frequently than with standard coiling. Standard coiling leads to about 2 to 3% rate of complication, permanent neurologic deficit or death, whether from a hemorrhage during the procedure, aneurysm rupture, or a thrombotic event. Using stents, this rate of complication goes up to nearly 10% of patients. Right. So,
but you're trying to sort of steer within quite a sort of narrow clinical window of causing the aneurysm to clot off, but maintaining patency of the vessel that's supplying the
exactly
the brain. So, so it's quite a delicate balance that you're actually trying to achieve here, isn't it?
Yes. That's why we require dual antiplatelet therapy, but we've seen and we've learned from cardiologists that one size does not fit all for clopidogrel and even aspirin. This is why monitoring of antiplatelet therapy has become very important for us to find the right therapeutic window for these two drugs.
So with these aneurysm treatments, at what stage are you starting the antiplatelet therapy? And does that depend on the type of procedure you're going to be performing, whether you're using coils or flow diverters? What are the considerations there?
For coiling, you do not require another antiplatelet, just aspirin, not dual. Clopidogrel is not necessary. And we only use aspirin during the procedure, single intravenous dose of aspirin. And however, for stent placement, dual antiplatelet therapy is required for at least 6 months and a full year on aspirin, and then aspirin can be discontinued.
Do you know before the procedure what you're going to be doing, or does it depend on how things go during the procedure as to what devices are selected?
No, everything is usually decided before the procedure. Patients undergo an arteriography, cerebral arteriography, and my neuroradiologist colleagues decide on which type of procedure which type of devices they need prior to the procedure. So everything is decided before, a few weeks, few months before, and when the procedure takes place, we usually know what's going to happen.
Right. And so for the patient who has the stent fitted electively, what do you do with the dual antiplatelet therapy then? What's your strategy there?
We used to use loading doses, as I think most interventional cardiologists and even neuroradiologists use, because they are quite simple. Patient comes to the hospital, he receives his loading dose, then he can be tested, found to be a responder to clopidogrel, for instance, and then the procedure can go on. However, we've had a few cases, one in particular in a patient who was a perfect responder after a loading dose of 300 milligrams of clopidogrel. We tested him just after the loading dose, a few hours after the loading dose, before the procedure. The procedure was uneventful, everything was fine. The patient was discharged after a few days, and he came back 8 days after the procedure with a stent thrombosis, acute stent thrombosis. And when he was tested at that time, he was a non-responder, and we knew for sure that he was still taking 1 tablet a day of clopidogrel. So our confidence in the efficacy of loading doses was shaken by this experience. It seemed to us that it was not logical to give a high dose of clopidogrel to patients, to find them responders, and then to send them home with 1 tablet a day without knowing for sure that 1 tablet a day would be sufficient for this patient. And we know that, for example, obese patients are more prone to be bad responders to anti-P2Y12 treatments, especially clopidogrel. And some authors are suggesting that all these patients should be treated under double dose of clopidogrel, 150 milligrams per day as a daily regimen. So we've decided to test our patients under a daily dose of 75 milligrams of clopidogrel, and if they are good responders, then we can go on with the procedure. If they are bad responders, we increase the dose, we wait another 5 days, we test them again, and if they are good responders, the procedure goes ahead.
So you're trying to establish the optimum treatment a couple of weeks, 2 or 3 weeks, several weeks before you actually do the procedure, so that by the time you get to doing the procedure, you know where you are in terms of your level of P2Y12 inhibition with the clopidogrel.
We refuse to take a chance for our patients. A small thrombotic event will not lead to a few myocardium cells to die. They will lead to acute stroke and usually permanent neurologic deficit. So we have to be absolutely sure that the regimen we have chosen for our patient is the right one, and it will be fully efficient for the whole duration of the treatment.
Now, we know there's many things that can influence the response to clopidogrel, but I guess in your patients with aneurysms, diabetes is relatively uncommon. Would that be
It's rather uncommon
to say? Yeah. And other things like renal failure, perhaps also uncommon.
Patients with renal failure are very complicated to manage. We're not exactly sure why. There are a few patients with kidney polycystosis. Is that what it's called?
Polycystic kidney disease.
Exactly, and they also have intracranial aneurysms, so they need to be treated. A few of them are even have kidney transplants, and we find it very difficult to find the right doses for these patients, but they're quite rare. We have them.
I guess sort of hypertension is the common link sometimes
hypertension
between
smoking.
Kidney disease and intracranial aneurysms.
No, it's more polycystic kidney disease, but there are only a few patients.
Yeah. Okay. And so some of those clinical factors that affect clopidogrel response seem to be less common in these patients with intracranial aneurysms, but what is likely to be common to all the patients is some of the genetic factors that influence clopidogrel response, and we know that the CYP2C19 loss of function alleles have a sort of modest effect on clopidogrel response, and I guess they'll be as prevalent in your population undergoing intracranial aneurysm stenting as in the cardiovascular disease patients.
I suppose this. To be quite fair, quite honest, we're very pragmatic. We don't understand everything. We just want our patients to be responders on the day of the procedure.
Yes.
So trying to explain why the patient is not a good responder is interesting for the science and for other doctors. But when you are talking of a specific patient undergoing a dangerous procedure with a high rate of complication, for that patient, he doesn't want to know why he's a poor responder, why he had stent thrombosis. He wants his doctor to turn him into a good responder, and this is what we try to do before the procedure.
So you've taken the pragmatic approach of just going straight to platelet function testing to establish whether they've reacted to their clopidogrel in the therapeutic way that you intend. And tell us a bit about the test then that you're using to assess the response to clopidogrel.
We use the Verify Now from Acumetrix. It's easy for us to use. It's very straightforward. You just need blood into a sample tube. Anyone can pass the tube through the machine. The nurses and the doctors of the anesthesiology department have all been trained to use the machine. And this is what we do when the patient comes to see us in the anesthesiology consultation. We do all the work we usually do before general anesthesia, preparing it, but we also start the patient on clopidogrel and ask him to come back 5 days later and do the testing. And we can give him the result. We obtain the result so 30, 40 minutes after drawing the blood, keep the patient with us, And if he's a poor responder, we increase the dosage to 2 tablets a day. And so he can go home and know that the treatment has been modified. If we use light transmittance aggregometry or the VASP test, which are very precious, they are very precise tests, but it's a little more complicated because the patient has to give blood, go into another hospital, and then the test is done maybe 2-3 days a week, but not every day in these hospitals. And then we have to call the patient again. So a bedside monitoring is for us more simple.
Okay. And do you have the machine, the analyzer in your clinic, or is there a sort of central place where you...
It's in the cath lab, a few meters away from the office of the anesthesiologist receiving the patient in the consultation, preoperative consultation.
Okay. And so tell us a bit about the complications, because you're obviously very concerned about the response to clopidogrel and what has been associated as complications with this technique. Just, can you give us some sort of case histories of, what's gone wrong with the procedure, with patients you've been involved with? Obviously not going into individual details, but just to give a sense of how catastrophic this complications can be.
Well, I've talked about a patient who was a responder during the procedure, who had a Y stenting of the basilar artery, and who came back with an acute thrombosis of the stents. So that's a patient that is in a coma, tetraplegic now, and with a posterior now handicap now. Even small thrombotic events cause stroke. So they can be catastrophic strokes when they are acute thrombosis of basilar artery, for example, or if we have a thrombosis of a stent in the anterior cerebral artery, we have frontal lobe syndrome, for example. So there is never a good thrombotic event. It's always bad for the patient and has dire consequences for the patient, and usually it leads to
disability or...
Yes, and
yeah.
Usually the patients go to court, and then they file a lawsuit against the hospital, so it has a lot of consequences.
Right, okay. So the patient's response to clopidogrel you see as a potential area of litigation in these patients. Is there an accepted standard practice that this could be judged by, or are centres tending to do their own thing, do you think?
Centres are still tending to do their own thing. The difference between cardiology and neuroradiology is the number of patients. Our hospital has the biggest activity in intracranial stent placement in France, and we have about 100 cases every year. So we can't be comparing our activity to cardiology, big cardiology centers. It seems to us that monitoring and tailored therapy has lowered the risk. We used to have catastrophic complications, and we have less now. We are analyzing our data as we speak, and I hope we can prove this with figures.
Yeah, okay. So what do you do then if you've doubled up the dose of clopidogrel, 150 milligrams, and they're still not responding?
There are a few case reports. That's all we have for the moment. There are two strategies. Well, three. One is don't treat the patient because it's too dangerous, and we've no way of treating him. Remember, this is these elective cases are patients are treated to prevent aneurysm rupture. We believe there is about a 2%, 4% chance every year that the aneurysm can rupture. It depends on the anatomy of the aneurysm. Yeah. So exposing the patient to a high thrombotic risk for preventing the rupture of an aneurysm that has never ruptured is a different matter from a patient with a acute coronary syndrome, for example. Yeah. So we might not treat this patient or find a surgeon who is able to clip surgically the aneurysm. The two other strategies are to change the drug to prasugrel or ticagrelor. But there are only a few case reports with a dozen patients from other centers who showed that they've turned a non-responder into a responder, but it's very small cohorts of patients, so we're not exactly sure what to do with these patients. We discuss them, each case is discussed individually, but it's only about 5% of patients who are still non-responders with 150 milligrams per day.
How are you defining non-response in your center?
We define patients as responders above 40% inhibition percentage with the P2Y12 Verify Now machine. Below 20%, we consider they are non-responders. Mm-hmm. And there's a gray area between 40 and 20%, and we're not exactly sure what to do with these patients. Recently, a paper in The Lancet identified the PRU at 208 to be a good threshold to distinguish non-responders from responders. So I suppose if we have, well, now we've talked about it since this paper came out a few weeks ago, and if a patient has, for example, 25% inhibition percentage and a PRU below 208, I think we'll go ahead with the procedure, considering that the thrombotic risk is not too high.
Okay, Jeff, do you want to sort of comment about this issue of percentage inhibition versus the PRU to assess response to drug and platelet reactivity?
Yes, it's a great question because most of the data that have been published have focused on the PRU result, and the percent inhibition result is also displayed by the instrument, but it's largely influenced by the PRU result. So there is a high degree of correlation between those two measures. However, there's also a range of baseline platelet reactivity, and that is the cause of some of the variability in the association between the PRU and percent inhibition. And I wanted to add that I find it very interesting, when talking about the different patient populations that are treated with dual antiplatelet therapy, because it always involves the selection of the drug and the use of the drug, but the end goal is the same, is to confirm that there's a drug effect present. And we sometimes hear about the differences between the different populations, but at the end of the day, the platelets are the same, and the goal of the treatment is the same. So it's always very interesting.
So whatever measure you take, you're really looking to see if there's evidence of a clopidogrel response. But in these particular patients where you're also concerned about bleeding, you maybe don't want too excessive a level of platelet inhibition. So there seems to be some sort of parallel there in terms of the strategies in elective coronary stenting and your procedures in terms of getting below this risk threshold that's associated with lack of adequate response to clopidogrel. So in terms of the alternative strategies, and given that the issue here is whether clopidogrel is being metabolized effectively to an active metabolite, and if it isn't, perhaps looking at prasugrel as an alternative, and you've got the sort of two doses that you can choose from, 5 and 10 milligrams, and there seems to be some sort of variability during maintenance therapy, given also that you've got several weeks potentially or indefinite amount of time in order to get things right. I guess that would be perhaps a sort of logical strategy that since clopidogrel active metabolite and prasugrel active metabolite are highly similar and working in the same way, that would seem to be a reasonable option. Yes. I guess people sort of would shy away from prasugrel as well as ticagrelor because of the issues with intracranial hemorrhage that we've seen higher risk. Is that a concern to you, that sort of, if you go too far, that you're going to put patients at excessive risk of intracranial hemorrhage during the procedure?
There's recently been a paper of interventional neuroradiology showing that the bleeding risk increases with the inhibition percentage result according to the Verify Now device. So it seems to us now that not only does one size does not fit all for clopidogrel, but clopidogrel seems to be like vitamin K drugs. There's a therapeutic window. If you go below a certain threshold, there seems to be a thrombotic risk. If you go above a certain threshold, there seems to be an increased bleeding risk. And we need to put our patients just in between. Now, we're not exactly sure when the increased bleeding risk starts for interventional neuroradiology, but we've had a few cases of patients with 90% inhibition percentage. That's a PRU maybe, I think, below 40 or something like that, who had inexplicable brain hemorrhage after a procedure that seemed to have gone perfectly well, with no aneurysm rupture. It was just a small hemorrhage inside the brain, not in the, and this hematoma sort of grew from day to day, and we lost the patient of a brain hemorrhage. And the only explanation we had was that he was a hyper responder with a very high inhibition percentage. We've had about 2 or 3 patients like these. So we're not exactly sure how to manage those patients. Should we change the therapy to another drug, or lower the dose of clopidogrel to maybe half a tablet a day or 1 tablet every other day, to lower the inhibition percentage or the PRU, or to increase the PRU to a certain threshold or range to protect this patient from the bleeding risk? Or should we withdraw the other antiplatelet, aspirin, and keep this patient under monotherapy? We've chosen the latter strategy for the moment, but we're not sure this is the...
You withdraw the aspirin?
Yes.
Yeah. Okay. And so with these bleeds, how quickly are patients tending to deteriorate? Can you have sort of catastrophic, sort of sudden
You can have both.
intracranial hemorrhage, or is it this sort of slow progression?
Usually it's slow progression with these kind of hemorrhage. If you have aneurysm rupture, it's a large hemorrhage, but it's usually instrumental. It's not because of the drugs.
So for the ones who don't succumb immediately, then you've got a bit of time to assess what's going on in terms of your platelet function and make a decision about how to address that and modify the level of platelet inhibition.
But it's usually a very difficult decision, because these patients have a hemorrhage, but they have a stent in place.
Yeah.
So we know if we withdraw all antiplatelet therapy, or if we use a platelet transfusion to acutely antagonize antiplatelet therapy, we'll have thrombotic events. And we've had that in a few patients with a hematoma. We transfused platelets, and next day the stent was occluded by thrombosis.
So you want to change the level of platelet inhibition, but you want to do that in a controlled way. What about dosing the platelet transfusion in a more cautious way? So half a unit, 1 unit, retest. How about and sort of titrating your level of response in that way?
It's a good idea. Unfortunately, it doesn't really work like that. We've found that, first of all, we always test our patients after platelet transfusion, always, to know what's going on. If you transfuse a patient under aspirin, he will become a non-responder 100% of the time. 30 minutes later, he's a non-responder when you test him. So there's no titrating there. Either he's a responder or he's not. For clopidogrel, we found patients with repeated transfusions who were still responders. And we can't really explain why, But we've seen that patients with 40% inhibition percentage, we transfuse them. We want to go to the operating room for external shunt placement, for example, and he's still a responder after platelet transfusion, so we transfuse them again, sort of 30 minutes later, and they are still responders. And we published this only recently, and there is no clear explanation for that. We don't know whether the active metabolite of clopidogrel might still be produced during the transfusion, so the new platelets are inactivated by the active metabolite. We don't know.
Well, we know that the active metabolite of clopidogrel clears fairly quickly, particularly in sort of healthy individuals, and so it would only be expected to be around at reasonably therapeutic levels for a few hours post-dosing. So I guess it depends on what the timing of the last dose is relative to these complications.
Exactly, but in emergency cases, we have no hold on that. We have to transfuse them. I mean, it's a matter of minutes or few hours at most.
Yeah. But if it doesn't work at one stage, then it should work an hour or two down the line when the active metabolite is being cleared, unless the platelets that you're transfusing and don't have normal reactivity, which may well be the case, particularly with ADP. So platelet transfusion, the platelets may well be desensitized to ADP, which is released during the preparation. We know platelet activation occurs during the handling of platelets, so it may well be that the reactivity of what you're transfusing is not normal, and so the P2Y12 test will pick that up, whereas the aspirin test is much easier for platelets to retain their ability to synthesize thromboxane A2 through the COX-1 enzyme. So I guess that's another potential sort of reason that what you're transfusing is not normal reactive platelets. But that, since you sort of observe these patients sort of swing to having ischemic events despite that, then maybe thromboxane A2 is very important in this in those events. Now, again, maybe smaller doses of platelets would, still get around that in terms of the mean level of platelet thromboxane generation. But I guess that's more difficult to judge with these types of tests. Jeff, do you have any sort of views on the aspirin test and how that relates to COX-1 activity?
Well, it's shown to be very closely associated because it uses arachidonic acid as an agonist, but also, it's an enzyme that, and there's many things that can affect the COX-1 enzyme, supplements and other things that the patients might be taking. But I think this is a very interesting area because the on-treatment reactivity and the measurements from the test depend on a number of factors, including the timing since the last dose. And that's not just the effect on the platelets that are already in circulation, but as you mentioned, the timing since the last dose also influences the level of the active metabolite that's present. And so that could contribute to the lack of success with a platelet transfusion.
And aspirin has quite a short half-life as well, so I mean that's cleared over a few hours. Are all your patients getting intravenous aspirin at the time of the procedure, or you're just relying on oral dosing in some?
Patients who have elective stent placement have aspirin, oral aspirin before the procedure. Patients who have simple coiling have intravenous aspirin. And we find that with high doses of aspirin, 250 milligrams, we have less than 5% of non-responders to aspirin.
Mm-hmm. Okay. Well, that's been a really fascinating discussion, learning more about some of the challenges that you face, and clearly it's emotionally difficult for the physician who's in this position where clotting and hemostasis really makes the difference between success and catastrophic failure, and at huge cost for the patients. So it's been a pleasure to discuss with you some of those issues that you're facing and how you're dealing with that in terms of this titration of therapy guided by a sort of rational way, although we still don't have clinical outcome study to support that, but it's taking a very pragmatic approach to this challenging problem in a relatively small population of patients. So I think that's been very interesting to learn more about your practice there. So thank you very much, Guillaume.
Thank you.
And thank you, Jeff, for your input.
Thank you.